everyone. Welcome to the Healthier You Show, a guide to living a healthy, active, and productive life. Now, please join me in welcoming the newest member to our team, my co-host, Alana Peffinger. Welcome, Alana.
Oh, thank you.
Alana's been a huge advocate of living a healthy and active life, and she's very actively engaging, motivating young professionals to adapt a healthier lifestyle. Welcome. We're so happy to have you.
I'm happy to be here and be part of the team. Thank you.
Now, our special guest today, Dr. Sam Nam, Medical Director of Palliative Care at the UCLA-Harbor Medical Center here in Southern California. Welcome.
Thank you, Andy, for inviting me to the show.
No problem. So now we're going to talk about advanced care. I know a lot of you might not have heard of that, didn't know anything about it before this. Now, Dr. Nam, tell us a little bit about Advanced Directive.
So Advanced Directive is a form that you fill out in preparation of emergencies that may happen in life, such as disease or any type of illnesses, and you're writing your preferences of what you want as a treatment option. But before we start talking about advanced directives, I want to talk about in a more broader spectrum of advanced care planning. Like the term states, it's a planning for advanced care. So you're planning for things that may come in the future. As human beings, we always plan things that emergencies or disasters financially. We plan for retirement, we plan for estate planning, savings just in case in emergencies. But when it comes to our bodies, we forget to plan ahead. We wait until bad things happen, and then we seek help. So by doing advanced care planning, you're planning the types of care you want and the options that there are available, and you're indicating your preference and talking to your family and your loved ones and your healthcare providers, like your physicians, to let them know what type of care you want.
Yeah, and another question I have is, I'm 28, but I do have parents that are 65 and up. They're in the baby boomer, age range. At what time, at what age, under what circumstances should you start considering these things and start getting things in place and having these conversations with your family members?
Right. So unfortunately, patients and people in the community, they think that advanced directive is more for end-of-life type of decisions, but that is not always true, because once you wait until your disease is more progressed and end stage, you're going to be having more difficulty determining what you want, depending on your values and your cultures as well too. So it's better to start planning ahead. So we tell our patients, even 18-year-olds and older, we tell them to start planning ahead, because you never know what's going to happen in the future. You never know what kind of disasters or emergencies are going to happen. So we tend to encourage our patients to plan ahead, have their preferences listed in the advanced directives, so that when those emergencies occur, you're ready to, and your family is also aware of your preferences so that they can take that treatment option.
Now, what does that process look like?
So the process is just the form. You can also find this on the website, and it's a 7-page form. There's also multiple other advanced directive forms out there, like the 5 Wishes and My Directives, which is an online type of advanced directives. But it's a generic form that you can fill out with your family or even with your lawyer. Of course, you don't require a lawyer to complete these forms, but you can also discuss it with your physicians. And the form requires signatures from 2 witnesses, and it cannot be your blood-related persons or someone who's taking care of your finances. It cannot be a person in like a nursing home or someone who works in a nursing home or in the hospital setting. Can't not be your doctor either. The witnesses have to be someone different or strangers, or sometimes you choose church members, so or people in the neighborhood, in your neighbor. So you need 2 signatures. If you're not able to find those 2 witnesses, then you can also have it notarized, and of course there's a fee behind that.
Right. And usually notarization, it's about $10 fee to do that. So now, can you give me an example of what sort of question are being asked in those forms.
Right.
And when, let's say, when I fill out this form, what are some of the things that I have to consider?
Right. So there's actually 2 sections specifically in the advanced directives. One is the durable power of attorney. You're determining the person who will be making the decisions on your behalf if you're unable to speak for yourself. So let's say if you have end-stage dementia or a stroke, or if you're in a coma and you're not able to make decisions on by yourself, then someone will step in to make that decisions on your behalf. But you want that person to be someone who you know well and who knows your value system well. And that person should be able to stand up for your beliefs and make sure the care that you requested are being given. You want also that person to be someplace nearby or easily reachable. So just in case if there's an emergency and we need to get hold of someone, that person will be available for you. I had patients who had big families, and they decided not to choose their family members, but instead they decided to go with their best friend because they've had long-term relationship and that friend knew them better than her children. So she decided to go with her best friend. And of course, again, like the witnesses, it cannot be your physician, it cannot be the healthcare providers or any of workers in the health system, unless, of course, it's your blood-related person. Or it has to be blood-related or someone you can count on. If that portion is not filled, then it would be the next person in kin of your family. So it can be your spouse or your children or your cousins or nephews, whoever is the closest to you. The second portion of the advanced directive is the living will. And you're filling out what type of treatment options you want in the setting of emergencies. The first one is the code status, also known as whether to proceed with CPR or not if you have cardiopulmonary arrest. So it's do not resuscitate or attempt resuscitation. Oftentimes, because we have so much of Hollywood involved in our lives, we see patients doing so well, and everyone survives through the CPR. But the hospital studies show that 15% of the patients survive CPR when they obtain the CPR, and those 15% are combining the old and the young, healthy and the sick. And so if you just look at the numbers of the elderlies, the persons of who have chronic diseases, is much less who survive. And it's not just a simple method. It's not benign type of procedure. You're actually compressing and pounding on the chest 2 inches deep to push the sternum into your heart to make it beat. And oftentimes you're pushing it hard enough where you're actually breaking ribs and it's puncturing the lungs. And sometimes you would have to shock the person. Sometimes you have to intubate the person with the breathing tube and have the machine breathe for them. And oftentimes patients don't really want to be kept alive artificially on a machine. So that's one of the things that is mentioned. Other things are nutrition. If you want artificial nutrition, is it temporary or is it permanent, like a PEG tube? Another thing is types of therapies like dialysis, blood transfusions, mechanical ventilators. So those are all the different types of treatment options that you can indicate in your advanced directives.
One question I want to kind of get back to is in part 1, you were talking about a healthcare proxy. So what if I was identified as a healthcare proxy? What type of rights, as far as like information, what kind of rights of the patient's information do I have access to? And what kind of questions should I be asking to making sure that the patient's wishes are being adhered to?
So you want to ask what type of care your loved one wants in the setting of severe illness or end of life type of settings. Does that person want CPR? Do they want to be resuscitated? Especially if the setting where if they're so chronically ill, it may not actually be beneficial to them and can cause actual more harm than benefit. Some of the other things are, do they want to just stay home with their loved ones and keep their dignity during the dying phase. And you can discuss about like what we talked about, if the patient would prefer transfusions, dialysis, those type of things are important to discuss.
Mm-hmm. And what kind of, I mean, if they're having issues making those type of decisions, obviously they can consult physicians. Are there any outside resources that sometimes you suggest them to talk to help them making those decisions?
So hospitals, they've done studies and they found that majority of the patients are getting end-of-life treatments or therapies that they really didn't want, mainly because no one has really discussed with them. They didn't have any advance directives in place, so no one really knew what they wanted. Family, of course, acts as in their best interest to determine what is best for them. And so the hospitals are realizing that maybe we're giving too much treatments, and which may cause harm and pain and no benefit in the overall outcome to the patients. So maybe we should kind of decide to change the course and give the patients more autonomy. So they've started initiatives to kind of push for advanced directives in the hospitals, in the outpatient settings, and also in the primary care physician settings. So what they started doing is they started having forms in the primary care physicians' outpatient settings, and when the patients come and ask for them, you can actually discuss those topics with their physicians. Also, oftentimes, outpatient settings, they also have social workers in the clinics, and social workers also are well educated in those type of discussions. So you can discuss advanced directives with your social workers and any type of healthcare professionals, sometimes nurse practitioners, nurses, of course physicians, and sometimes chaplains can also help with that, especially if you're religious and religious values are very important to you. Then it's always good to kind of discuss it with your minister or your rabbi or whoever in the community can help you with those things.
Now, my question is, can advance directive be modified after it's already in place?
So that's a great question. Advance directive is not a permanent documentation. So of course, we would honor the documents, but if let's say your health changes and the treatments that you chose were not appropriate, or maybe you're getting better and you do want certain type of new therapies, or there's development of new therapies, like for cancer or whatnot, and you want to change your decisions, then of course you can always go back and redo the form, write out a new form. But you want to either discard the old one or write revoked on it so that we know it was the previous advance directives. Once you complete the new one, you always want to let your physician know. You also want to let your loved ones and your families, your friends know of your new decision so that we can honor them. And always keep the advance directive in a safe place.
That's what I was going to ask. Where do I actually put them?
And always keep a copy and give a copy to your physicians and to your loved ones as well too, so they're aware of what's going on. And also sometimes you can give it to your hospitals as well too.
Interesting. So I hear you talk about the advanced directive form as well. You mentioned 5 wishes. I know there's also something called POLST, which is another form that people are electing to use. Can you explain a little about what that form is?
Sure. So POLST, again, you can go to the website to see what it looks like. That is a bright pink form, and go to the website to take a look at it. And it's easily identifiable, and it follows wherever the patient goes. It doesn't replace the advanced directives. It's a complement to advanced directives, and it's a physician order. So when a patient goes to the hospital, the form follows the patient, and the physician has to follow that order. There is a law that passed in the legislative law, so that it has to be honored when the patient is admitted to the hospital. It has several portions. The first portion, of course, is the code status, whether you want to be resuscitated or not. The second portion is type of therapies, whether you want a full therapy, aggressive therapy, or you want some kind of limited therapy where you're not really looking for major surgeries or type of aggressive interventions. And the third one is just comfort measures for patients who are have maybe weeks to maybe a couple of months left in their lives, and they just want to focus on comfort, only with maybe IV medications, IV antibiotics to promote comfort, maybe oxygen, simple things like that. And then, of course, either the patient has to sign that note, or a caregiver or a durable power of attorney will also will either sign for the patient, and then the physician has to sign to make sure it's an actual physician order. And the form, you want to keep it where it's easily identifiable, whether it's on a fridge or someplace, and so that when emergency personnel comes into your house, they're easily be able to find your form.
I might have missed it. What does POST stand for?
So it's a physician order of life-sustaining treatment. And POST is usually filled out when you think you don't have much time left, when you're chronically ill with severe illness, like end-stage dementia, end-stage congestive heart disease, lung disease, kidney disease, and so that's when you fill out the form. The one phrase that we use is, would you be surprised to live after 1 year? If you're not surprised, then you should have a POST filled out.
Interesting.
So then is there something comparable for advanced directive?
So there are other types. I just went over the generic type of advanced directive, but we also mentioned earlier about 5 wishes and also my directives. Those, the 5 wishes, it gives you 5 different things, very similar to advanced directives, but it comes in statements. And if you agree with the statements, you leave it as it is. If you don't agree with the statements, you cross them out. And unfortunately, you have to pay for the form, so it's not free like the generic advanced directives. And every state has their own requirements for the advanced directives, so before filling one out, make sure it's proper for your state. The My Directive one is an online type of directives, so that you can just go online and complete it. It's very similar to the generic one, and you can keep it on file so that anyone can access your account and get information when there's any type of emergencies.
I see. Interesting.
Yeah.
Yeah, that's a great learning section. I was just telling Alana before we come on to the show that I had never heard of the term actually, and it's so interesting to learn that there are so many different things out there we have to look out for, and especially when it comes to patient care. Now, based on your personal experience, what has been the most challenging aspect of implementing this new initiative?
So oftentimes patients are afraid to talk about their serious illness and end of life. And of course, physicians, most are not well trained as well, so they feel uncomfortable discussing those topics as well. So now the hospitals are starting the initiative to kind of enforce patients to fill out the advanced directive, but however, it's not a requirement, or you don't have to have one, but we're just requesting that patients go out and fill it so that we would know what their preferences are.
And I don't know if you mentioned this earlier, but when you see patients and kind of get into those end of life issues and whatnot, what proportion do you find actually have these advanced directives in place?
So we don't have a specific number nationwide, but patients who are home with home health, meaning they have visiting nurses, meaning they're very ill, less than a quarter of those patients actually had advanced directives. So it's not really being discussed, it's not really being talked about, and it's very important to have it filled out. One case, I had 80-year-old male with severe heart disease, with coronary artery disease, and he was found down. His wife, unfortunately, had a form of dementia, and he was a caregiver. So he was rushed over to the hospital. He was admitted because of the heart attack, and then was found to have cardiopulmonary arrest. He was having irregular heart rhythms, and he wasn't breathing on his own. So unfortunately, because there wasn't anyone to get hold of, and the wife was demented, they started the CPR. They started compression shocks, intubation, breaking his ribs, causing pneumothorax, putting in a chest tube to get the air out from the lungs. And then eventually we found his son after a couple of days. And apparently son had discussed with his dad that he would have not wanted all these measures. But because they didn't write it on a paper or have not really discussed it with the healthcare provider, we had to go through all those painful and harmful type of procedures, even though he did not want that.
The first step we could take if we were in the position or thinking about advanced directive will be talking to our health providers.
Regardless of your age, whether you're 18 or 80, you want to prepare for emergencies and disasters. So you can go online and print the form out, or you can go to your physician's office and get the form there. And if you have any questions, of course, they're available to discuss that with you and try to fill out the form. And get it notarized or have two witnesses who can sign on your behalf, and then the form is then certified too.
There's a lot of, there's just those issues that you don't think about, but it's enlightening to hear you say even at 18 this is something you should be thinking about, because for me it's been completely off the radar. I mean, it really wasn't until I started doing this type of research that I was kind of learning about all these issues that you do have to consider. And ultimately at the end of the day, if you want to make sure that what you want is being carried through upon, you need to have it written down.
Right, because if you don't have the advance directives, you're putting your families under stress and anxiety to figure out what kind of care you want. And oftentimes because they're stressed, they have difficulty figuring out what you would want and to know exactly what type of care you would require. At one point I had a patient, a demented patient living with her daughter. Was because demented patients often have difficulty swallowing, they tend to have aspiration and aspiration pneumonia infections. And she had aspiration pneumonia, had shortness of breath, and was admitted to the hospital. The daughter, of course, because she lived with her, stated that she did not want any further aggressive management but other comfort measures. But the son, who lives in New York, even though he's only seen her maybe 5 years ago, said that she was able to talk and able to move around and was fully functional. So he kept insisting that we need to go in and do aggressive measures. So there was that family conflict, and we do see that quite often.
Wow, what very interesting. Thank you so much for educating us and our audience about the importance of having that advanced directive measure laid out way earlier on, and good planning too. Now let's transition into something completely different. Talk about healthcare, with the Affordable Care Act. And what do you see as the future of healthcare in America?
So it's a very exciting time for medicine. We have a lot of changes happening currently. One, you mentioned Obamacare, and that is to insure the uninsured. And so we're having influx of patients coming into the hospitals requesting for care. Some hospitals are not really prepared for that type of influx. So they're preparing themselves to staff more appropriately to care for those patients. And also patients now have rights. Those who were uninsured usually went to a county hospital or like emergency rooms. Now they have the right to choose their own physicians and go into their own hospitals of their choice. And so it's very exciting time, and it may be challenging as well too.
Now, when you mentioned about challenging, what would be the most challenging thing for physicians, for providers?
So one is the numbers of patients. We're getting influx of patients, so we may need to see more as well. And the reimbursement as well is too. There are changes in some reimbursement measures. They're recommending less procedures and less reimbursements for the specialists as well too. And there's also ACO is a new thing that's coming out from the Centers of Medicare and Medicaid Services, and that's the accountable organization where you get like a bulk payment for a type of specific disease like heart failure, and your cardiologist and the hospital, they're all supposed to work together to use that amount to get the amount that you got paid to pay for the care. So if the patient keeps being readmitted frequently, you have to use up from that account. And if you run out, that's your loss. You have to pay from your own organization. So that's going to be a new type of changes in the medicine, which can be challenging, especially patients with end-stage organ disease where it may be very difficult to take care of.
And I know you work in a county facility, so you're talking about how you guys are kind of restructuring your staffing. What kind of measures have you guys taken within your own hospital to kind of account for the influx of patients?
So, of course, we're hiring physicians and nurse practitioners and other health care providers. Now, because the patients have choices to go wherever they want, we're going to be losing a lot of uninsured patients that usually come. So we need to start catering to our patients and to make sure they're satisfied with the care. So instead of focusing on just treating and sending them home, we're actually focusing on patient-centered care and the quality care.
Interesting. Oh.
So when you mentioned about patient-centered home, I remember briefly hearing a concept of center of excellence. Is that somewhere along the line of the future of patient care?
So patient-centered care is where we're all moving towards to, because we want to do what the patient wants and not be doing things against their will.
Right.
So patient-centered care is the main thing that we're focused on.
Sounds like it's a great outlook for the future of healthcare in America, and I think we all we all understand that each challenge only will embolden us to progress forward. Thank you so much,
you're
Dr.
welcome.
Nam, for sharing with us about Advanced Directive, and for the audience watching, thank you so much for tuning in, and we'll see you next time.
Thank you.
Thank you.